So I'm going to speak on a different topic. I first wanted to just ask, as a show of hands, how many of you have ever worried about the cancer risk of cardiovascular therapies? Okay, well, hopefully I can reassure you that you don't need to worry about that after I'm done with my presentation. But it's a different perspective on the theme of cardio-oncology that I'm going to talk about today and share with you some of my own personal experiences and others to say that this has arisen. This is I think part of the whole cardio-oncology perspective, and I'll go through that today. So these are my disclosures. So I think Dr. Carr nicely showed that cardiovascular disease and cancer are concurrent illnesses. The population demographics and the risk factors are very similar, things such as older age, smoking, and other risk factors. Treatments for cardiovascular disease are chronic and administered for years to decades after someone is initially diagnosed, and so they're chronic treatments and have a long-term exposure for most patients. Patients who are treated with cardiovascular treatments who develop cancers are typically categorized into three different ways. The first is that they have pre-existing cancer, but yet was probably not identified by the time that their cardiovascular disease was diagnosed and initially treated. Second is that they could have a recurrent cancer, meaning that they had cancer previously, it was treated, and then it recurred while they're undergoing treatment for cardiovascular disease. And then the third is that they could have a newly occurring malignancy or neoplasm that just develops concurrently while they're on cardiovascular treatments. And many cardiovascular medications have been implicated as potentially associated with an increased risk of cancer, including antihypertensive medications, most notably angiotensin receptor blockers, lipid-lowering agents, antiplatelet agents, and diabetes therapies. And I'll show examples of many of those drug classes in my presentation. So if we look at the potential cancer risk with cardiovascular treatments, we have three different drugs that I'll highlight. Prasugrel, which is a antiplatelet agent that's administered with aspirin after coronary stent placement and after acute coronary syndromes. Sitagliptin, which is a inhibitor of the DDP4 enzyme that degrades incretin hormones and stimulates an insulin response from pancreatic beta cells and is used as a treatment for diabetes. And then ezetimibe, which is a drug that blocks small intestine absorption of cholesterol and lowers LDL levels, typically administered together with the statin. So let's first talk about Prasugrel, which was a drug that I was involved with, and a study performed now almost a decade ago, the Triton study, looked at patients who had an acute coronary syndrome, usually a heart attack or acute MI, who were planned to undergo PCI, which is our term for coronary stent placement. That's just an acronym we use in cardiology. In this study, patients all received aspirin, and they were randomized to standard drug clopidogrel or Plavix that I think most people probably know, or this new drug, Prasugrel, which is a more potent platelet inhibitor compared with clopidogrel. Patients were treated for a median of 12 months, and the primary endpoints were cardiovascular endpoints, as we typically see in our studies. However, an interesting observation was made when adverse events were looked at when the trial was completed. So as you know, in any randomized clinical trial, we'll be collecting serious adverse events and adverse events as part of regulatory guidance, and we categorize those into different organ and system classes. And so neoplasms that were benign, malignant, or unspecified were shown to potentially be higher in the Prasugrel treated patients compared to the clopidogrel treated patients, difference of 2.6% compared to 2.1%. And there was a potential also slight increase in the risk of malignancy-related deaths. However, this trial was a cardiovascular trial, and it did not have any specific inclusion or exclusion criteria related to cancer. It did not prospectively collect data on risk factors for cancer, on previous cancer history, tumor burden, etc. And there was no protocol-defined analytical plan for cancer. This was just a side observation that was made when the trial was completed. So the FDA required the investigators, who were colleagues of ours up in Boston, to go back and collect additional information from patients in the study after the study was completed. And anyone who had a neoplasm-related adverse event had additional data collection. And as a result, with input from the FDA, they reclassified patients, and they felt that there were an increased risk of new non-benign neoplasms in patients treated with Prasugrel compared to clopidogrel, as shown here. And when you look at the Kaplan-Meier curves, you can see that the curves primarily overlap except towards the end of the study when they tend to diverge just a little bit, but this is really not that big of a difference. And it's a low incidence. It's over more than a year, the incidence is less than 2%. And so the FDA Division of Oncology Drug Products actually consulted with the Cardiorenal Division where this product was being reviewed, and their interpretation was that these analyses were not conclusive. The study was not designed in a way to compare cancer incidence, did not include cancer screening at baseline, and they had no data in the study to support a belief that this drug is a promoter of cancer in humans. Remember, this drug exposure was just over 1 year, whereas most drugs that are carcinogenic only show that risk over many, many years of exposure, and the cancers diagnosed were likely to be incidental. However, based on these findings, there was a regulatory mandate to compare cancer incidence in the second study with prasugrel, which is one that I helped to lead here with one of my colleagues from Duke, Dr. Magnus Oman. And we studied the same treatment, prasugrel compared to clopidogrel, in a different type of patient with acute coronary syndromes, those who did not undergo coronary stent placement. And we were required by the FDA to collect detailed information at baseline on cancer history, and then during the study on cancer development as well as cancer screening practices. And I'll share some data that we just recently published on this. The things to recognize are that these are global studies, and so here we're in Duke, in North Carolina, in the United States, but in all of our large cardiovascular studies, we conduct these in typically up to 50 countries worldwide, and this is just an example of showing the countries that contributed patients to this trial, up to 52 countries with 8 different geographic regions. And so when we look at cancer incidence, there are a number of different regional factors that we should consider, and I'll discuss that, but it's important to recognize how we're viewing this. So what we showed here is looking at patients who had a new non-benign neoplasm detected in yellow compared to those who did not in blue, and looking at how do cardiovascular and bleeding endpoints track with cancer. And it's clear that in patients who develop cancer in this study, the risk of death is much higher. That's not a surprise, but the risk of other cardiovascular events like MI or stroke is also higher. But the risk of bleeding is substantially higher. Now remember, these are antiplatelet drugs that we know a side effect is bleeding, and typically when cancer develops, those drugs are stopped because you're getting cancer treatments that could increase the risk of bleeding. But often the cancer is identified first by bleeding, and then that leads to an investigation that may identify, for example, a colorectal cancer for that matter, that the increased intensity of antiplatelet therapy may have uncovered an early tumor in that regard. Now we look at factors that were associated with the detection of a new neoplasm event. Clearly older age was a factor, but only up to the age of 70 years. And I think as Ravi Kara showed that after a certain age, the cancer incidence starts to go down. But in younger age, we know that as patients are older, they have a higher risk. But region was the second most prominent factor associated with the detection of neoplasm. And the reason that we saw this was that cancer screening practices were vastly different over various regions of the world. So in North America, the US and Canada, and Western Europe and Scandinavia, the likelihood of cancer screening was much higher. And the type of cancer screening that we typically do would be prostate cancer screening with PSA, mammography for breast cancer, colonoscopy for colorectal cancer. And we saw that, not a surprise, those are the 3 types of cancers that were most prominently detected and strongly associated with a cancer screening. So in other countries and other regions of the world, those patients may have had early cancers that just were not detected because screening wasn't being done, and that's different in different healthcare systems. And when we looked at treatment-related differences in cancer incidence, there were none. And this was in a rigorous, prospective fashion that actually was quite resource-intensive and quite expensive, but at the end of the day, we showed that this drug didn't increase the risk of cancer compared with the comparator, which was clopidogrel. Now, let's turn it to an anti-diabetes therapy, sitagliptin that I talked about. The FDA now requires that diabetes therapies have cardiovascular safety studies conducted because there is a concern about the cardiovascular risk of diabetes therapies. We have to do international, large global studies to look at this, and this drug was assessed in a trial called the TICOS trials that my colleagues at Duke helped to conduct and run. This trial also was a global study that had patients from all regions of the world in numerous different countries, up to almost 15,000 patients, again, showing that these are global studies. When we look at the risk of cardiovascular endpoints in the study, there's no difference between the drug sitagliptin and placebo over different time frames. So this trial showed that there was no difference in cardiovascular risk with this therapy, but the FDA required that malignancies be assessed and adjudicated in this trial because, again, there was a putative concern that this drug was a cancer promoter. And lo and behold, no difference was shown in the risk of malignancies between sitagliptin and placebo. The most common types of malignancies, as I said earlier, prostate, lung, colon, and bladder. Breast cancer wasn't as prominent because the population was more predominantly male, and which is what we see with diabetes as well as cardiovascular disease. And then finally, a lipid-lowering therapy, the drug ezetimibe, which in previous trials was potentially associated with the risk of cancer, was studied in a very large trial that we helped to run at Duke called Improve It. 18,000 patients who were followed up for a median of 6 years after they had an acute coronary syndrome, which is typically an acute MI. Earlier studies suggested that this drug may actually be related to cancer risk by inhibiting intestinal absorption of phytosterols that may actually be inhibitors of cancer proliferation. And so 2 previous trials, one in aortic stenosis and one in patients with chronic kidney disease, had different results with respect to the incidence of cancer with this drug. And so the FDA required also that in this large trial that cancer incidence be prospectively collected and adjudicated. So this was done in a very rigorous fashion. It was done by our colleagues up at Boston at Dana-Farber Cancer Institute and the Brigham and Women's Hospital. And this was a big effort. They detected almost 1,500 cancers. Again, the different organ types are shown here. Most common lung, prostate, colon, and bladder cancer, as we've shown in other studies. And looking at treatment-related differences, again, there were none. Now, this trial followed patients for 7 years, and so the incidence of cancer at 7 years was just above 10% in both treatment groups with no treatment-related differences. And so there's clearly a linear accrual of cancer in patients with cardiovascular disease that is concurrent and is not intensified at the time that the cardiovascular disease appears, but clearly is linear over time. I don't think you could see a more linear curve than what is shown here. So in conclusion, the putative increased risk of cancer associated with several chronic cardiovascular treatments has not been confirmed in numerous large-scale, rigorous prospective ascertainment programs in global cardiovascular outcomes trials. All of these were required by the FDA primarily, by regulatory authorities. When neoplasms develop in patients on cardiovascular treatments, they're associated with a higher risk of mortality, other cardiovascular endpoints, as well as bleeding and other things. But it differs dramatically across regions in terms of detecting neoplasms, and that relates to differences in cancer screening practices. And we're trying to make sure that the regulatory authorities understand that and that their mandates to do these types of expensive and resource-intensive programs really can be quite confounded based on differential regional enrollment in these studies. And then finally, I think that the scientific concerns, regulatory concerns about cancer risk for chronic cardiovascular treatments really should be mitigated by these recent experiences that I presented today, and hopefully put to rest this concern that cardiovascular treatments are cancer promoters, and that really there's a lot of confounding here, and we need to think more broadly in the future about the concurrence of cancer and cardiovascular disease and how we can best assess this in ways that are meaningful but also not hugely expensive. So thank you for your attention to this presentation.